Hello and welcome to the Christopher Hall Training Podcast. In this episode, we're going to be talking about a limitation to the Mckenzie Method. So without further ado, let's get into it. The Mckenzie Method is a method used to overcome lower back pain. And we're going to talk about a concept within that is from an anatomical perspective and a certain lower back pain perspective is correct, but that's around that is where the limitation lies, and how the method is being used is where the limitation lies, not necessarily in the information itself, because the information itself is correct if used in the right way, and that is kind of where the limitation lies. So the concept that we're talking about is centralization. Now, centralization is basically when you get a certain type of lower back pain, you can get pain going down the back of the legs, and when that pain begins to regress back up the legs into the buttocks and into the central part of the back, that is what is known as centralization. And as a means of describing it to people, as pain changes, things are changing, which is a good thing. So from that perspective, as the pain goes back up the legs, be it the right or the left, then pain sort of structures are changing within the lower back, or how they're responding to the lower back, and therefore the pain is changing, and therefore the pain is regressing back to where it came from. So that, in a very brief nutshell, is what centralization is. But I guess the first part of the limitation to how it's being used is not all lower back pain goes down the legs. So you can't really categorize it as lower back pain. You have to categorize it. So lower back pain would be the umbrella term. That's fine. But there are many different types of lower back pain that sit underneath that umbrella term. And not all of the different types of lower back pain have pain going down the back of the legs. That can just be categorized as sciatica. And again, we have to then think about the symptoms, because when we get pain going down the back of the legs, it can be sciatica. It can also be two other things which have very similar symptoms, which have to be understood. So the other one is glute medius or glute minimus trigger points. Now, depending on the trigger point will depend on how far down the leg it goes and where in the leg it goes. So again, that has to be understood. And then the other one is piriformis syndrome. So that is another, what would you call it, condition that has symptoms that go down the back of the leg. Or it's certainly in the buttock, but down the back of the leg. So again, that has to be understood. So it wouldn't be a limitation if that was all being understood and taken care of from a evaluation and assessment perspective. Now, this is Robin Mckenzie's Treat Your Own Back book. Now, again, I understand that doesn't hold all the answers, but it doesn't necessarily talk about sciatica. It talks about lower back pain as the umbrella term, but it doesn't subcategorize it and sort of break it down and say, if you have sciatic symptoms or sciatica, then this will be advantageous for you. It then doesn't also mention glute medius, glute minimus trigger points. It doesn't mention piriformis, because they all have the same symptoms, but you have to understand the different cause to the same symptoms. So if someone presents with pain going down the back of the legs, you can't just jump in and start using Mckenzie Method because it may not be true sciatica. It may be that it's a hip trigger point or that it's a piriformis syndrome. And I've been able to experience not me personally, but working with people, experience all three. So someone has come to me with pain going down the legs, we've evaluated it, we've understood it to be piriformis syndrome, we've worked on the piriformis syndrome, and the pain has gone. Again, not always the same symptoms, but similar symptoms in that they're going down the back of the leg. Sometimes the different parts of the leg will help us understand which one it is, but we've similar symptoms gone down the back of the leg. We've understood it to be hip trigger points. We've worked on those. It's gone. Same with sciatica. We found out to be sciatica, and we've been able to reduce the symptoms. So we've got it to a point where we can understand that, but that has to come through some degree of evaluation. Just by presenting with pain going down the back of the legs and saying, right, do this extension movement, do this flexion movement, whatever it may be, isn't necessarily the way forward and the thing to start doing. What we have to understand is, again, as I've mentioned before in other videos, is we have to understand lower back pain as the umbrella term, and then we have to understand what the specific lower back pain we fall into, which we then need to go through some sort of assessment process. The second point on this is if we start doing a Mckenzie method type, and this goes for any method, and I'm using the Mckenzie method because this is what we're talking about in this tutorial, but this goes for any method. What if it doesn't change? What if it doesn't centralize? And what if it makes it worse? Now, again, as I mentioned, this goes for any method. Sometimes I will be treating someone. I'm constantly asking for feedback during the session, after the session, before the next session, so on and so forth. And I'm always asking, how's it feeling? Scale of 1 to 10, has it changed? So on and so forth. Change location, change intensity, all that kind of stuff. And the basic idea of asking those types of questions, is it working or not, is to understand, is what I'm doing changing it? If it's not changing it, I need to change what I'm doing as the therapist. And this again goes back to when I get a lot of people who contact me saying, I've done this, I've done that. Again, not necessarily Mckenzie method. But I've done this, I've done that, but Mckenzie method does come up. But it's not changing, it's making it worse. I go and see another one, they do exactly the same, it doesn't change, sometimes it makes it worse, so on. So that's a sort of a repeating pattern. Well, the first thing is just to stop doing it, because if it's not changing during the session, or at least after it, or a week after it, if it's not starting to change, then we need to start thinking about something else, because there should be some changes if you go about understanding the trigger. If you can understand the trigger well enough, you stop doing the trigger and then the pain will start to reduce. So you need to find out what that is, and then the therapy becomes that much easier. So what if it's not working? Well, the first step is to stop doing it. And it's useful to know that, and I'm going to put the link in the description below, but I've got an article here from the British Columbia Medical Journal. Now, what's great about this is it's written by someone who teaches for Mckenzie Institute International. So one of the competing interests of this article is Mr. Davis receives fees for making presentations and conducting courses on the assessment and treatment of spinal and extremity joint problems for Mckenzie Institute International, an education and research organisation. So that was one of the authors of this article. So I want to make that very clear, because what he says here is a low-tech clinical examination using patient symptomatic responses to active lumbar test movements can provide a primary care physician with an effective early sorting tool for differentiating the responder with a highly prevalent and rapidly reversible mechanical problems from those non-responders. Now that's very important, because in this article he says that some people respond and get the centralisation and some people don't. So what we have to understand is there are limits to what Mckenzie Method can do, and it may be, if someone isn't responding to it, it is to change the method completely. It may be tweaking the method, that may be fine, but that has to be evaluated, and the individual has to be taken into consideration here, because some individuals who have back problems want the back problem gone. If something isn't working, they may not have the patience to be able to go through that whole process with the therapist. They may have just lost confidence in it, and it's like, this isn't working for me, I need to try something new, but the therapist is insistent that we need to keep going. And the therapist in that scenario just kind of needs to let go of it and just say, that's no problem, go and find another answer, and if you need help from me again in the future, then I'll be here to help. So, and I will say that's how I respond to people, because again, we have to do our best to find the trigger. Sometimes it doesn't work. Even I will admit that. Sometimes it doesn't work. And we have to be able to allow the individual their autonomy in it to be able to go and find the answer that they're looking for. So what we have to understand is that when it's not working, we have to sometimes stop doing it. If the patient has the patience and they want to continue working with you, then by all means, tweak it, change it, do whatever needs to happen. That's absolutely fine. But what we have to be able to do is we have to be able to use different outcomes. So as an example, when I'm working with someone, first of all, I have to understand where the pain is coming from. That's fine. And then sometimes there is more than one way of treating that. So what I'm able to do is, okay, well, first of all, let's start here. Let's try this. Is this working? It might do. Okay, let's carry on. Let's add this in at a later date and this in at a later date. Okay, we identified, let's try this. Okay, that's not working, or that's not having the desired effect. Well, let's take that out, bring something else in. Is that working? That's working. Okay, well, this is what we need to do for you. This is what we need. This is how we need to move it forward. So again, we need to be constantly testing and measuring different outcomes, or different methods, so we can get the desired outcome. So we have to be able to have that adaptability in our toolbox, as he mentions here, because it's a sorting tool. That's what we need. Mckenzie Method is just one sorting tool, just like other methods are and other tests are. They're one sorting tool. So the more tools we can have, the more we are able to sort out the problem. So for the patients, if it's not working, then the easiest thing to do is stop doing it, because you're just constantly trying to ram home something that isn't working. So the easiest thing is just stop doing it, reevaluate, and go again. And finally, what if pain isn't going down? You've got lower back pain, but it's not going down the back of the leg, because not all lower back pain goes down the back of the leg. There are different types of pain that people can experience. Pain can be driven from the facet joint. Pain could be driven from a traditional disc bulge. It could also be an end plate fracture, so the disc can then move up into the vertebra. But all of these elicit different types of pain. You've then got spondylolisthesis, you've got stenosis, so you've got all these different types of pain that could be coming from the lower back. Again, the Mckenzie Method and the idea of centralization is all around the idea of sciatica and disc-driven symptoms that go down the back of the leg. If that isn't there, or if that hasn't been assessed, and you're treating something with lower back pain, because again, in Robin Mckenzie's book, he talks about it as lower back pain, not as sciatica necessarily. And also in this article, he talks about, again, this is another little caveat to it. He talks about when we have, what does he call it? Incompetent annulus. So essentially a disc herniation where the material, the annulus, is coming through the disc and out. He says that's not necessarily, or people won't respond in the same way. So if they have a disc bulge, that will respond in the way you want it to from the Mckenzie method. So they will be responders. Non-responders, as a general rule, if they have a disc herniation, they won't respond to the Mckenzie method and the sort of the extension or flexion postures. And the same has been said about the disc height as well. So if they lose 30% of disc height or 40% of disc height, they won't respond to Mckenzie method as well. So again, there's all these little caveats that come into the Mckenzie method and any method, as I will always say, because there are limitations to everything. As I've said, there are limitations to the things I do. There are limitations to the thing McGill does. There are limitations to the things that Mckenzie does. There are limitations to everything. Any trainer that's teaching exercises, there will be limitations to their style of training. That's just a given. So we have to understand those. So as the trainer, as the therapist, as the individual, we have to understand strengths, limitations, and then we are able to understand who we can work with and who we can't work with, if that makes sense. That, I hope, is something that I am able to bring to the table with regards to people going through the assessment process. That's why when people go to the How to Overcome Lower Back Pain page, they have to answer 3 questionnaires. What that allows me to do is that tells me whether I can help them or not, because they write all their answers down and they go, and I can look at it and say, yeah, this is something we can do about, this is something we can do about, this is something we can do about. So they're kind of giving me all the answers that I need to be able to say, yep, I can help with that, I can help with that, I can help with that. Maybe I can't help with that, but I can help with these other things. So I'll be able to set everything up straight for them to be able to say, yes, I can help with this part of it, but I can't help with this part of it. And that's what all comes through in the questionnaires. So again, what we have to understand is that not all pain comes from the disc. Not all pain will go down the back of the legs. There are different types of pain. There are people that respond and don't respond to it. So disc herniations, as a general rule, don't respond as well as disc bulges. Same with disc height. If you lose 30% of disc height, you don't respond as well to it either. So again, we have to understand all of these different things before we can start giving the correct response or method or rehabilitation for the individual, because it may not include what we are qualified in, and then we just have to pass it on to someone who is qualified in it. But if there is some part of it that we are able to help with, then that's what we can help with. I work with a number of physios, chiropractors, sports massage therapists, and take care of sometimes the exercise part of lower back pain, whereas they take part of a different part of the lower back pain rehabilitation. So again, it has to be used and utilised in that way. So hopefully that's given a little bit more context as to the Mckenzie method, some of its limitations. Again, if it's used in the right way with the right people, then no problem. There's nothing wrong with it. But what we tend to find in the industry as a whole is when people get hold of a method, they try and plug people into the method. And they just try and get them on the conveyor belt and get them going through. And if it doesn't work, well, then there's a problem with the individual. And there's nothing wrong with the way that we've assessed the individual or taken the individual forward. I think we need to go about taking the individual, listening to the symptoms, and then fitting what's needed, fitting what tool to what symptom is a much more advantageous way of rehabilitating. And that's what I try and do, again, within the capacity that I have, with the qualifications and experience that I have. Sometimes I may have to pass it on to someone else, or at least pass on this part of it I can't do anything with, but these parts I can. So again, there are limitations to what I'm doing. So don't think I'm up on my soapbox or high horse saying, you lot down there are all don't know what you're doing and I know exactly what I'm doing up here. That's not the case. The only difference maybe is that I understand that I have limitations and that I have things where I know my experience, qualifications lie. So I'm able to be more selective and specific about where I can make benefit and where I'm not going to make any benefit, so I can leave that alone. So hopefully that's been helpful. Hopefully it's given you a better idea of how I work, possibly in an indirect way. But hopefully it's given you a better understanding and understanding your lower back pain and lower back pain as a whole. So many thanks for watching. My name is Chris. I'll speak to you in the next episode.